Hello, I'm Dr. Maury Markman from City of Hope, and in this week's segment of Minutes with Markman, I would like to continue the discussion I began last week on the role of the physician/oncologist versus the clinical cancer investigator and the realistic tension that can result from these two roles, different roles that are attempted to be fulfilled optimally. Let me make it clear, this is not a new issue. In fact, in a wonderful book, a 1982 autobiography of Morris Abram, who was a very well-known civil rights lawyer who had unfortunately developed leukemia, there's a description of an event that occurred during his care when he was interacting with a very prominent clinical cancer physician and investigator. In this intense discussion with Mr. Abram and his daughter regarding participation in an experimental trial, the physician/investigator commented, quote, "My duty is to advise. You must bear in mind that I am not your father's physician. I am an investigator," end of quote. Yes, but the question is to advise as to what is in the patient's best interests, or merely that a trial is available, or perhaps, more concerningly, is more the priority of the investigator, the investigator's institution, or perhaps some other third party. This is not a trivial question, and the potential to subject the subject to unwarranted risks is very real. Consider, for example, an experience that I have previously discussed, including in a peer-reviewed commentary. Liposomal doxorubicin had been approved years before this particular event by the FDA as a single-agent treatment for platinum-resistant ovarian cancer. The initial dose approved for this indication was 50 milligrams per meter squared of pegylated liposomal doxorubicin administered once every 4 weeks. It was quickly recognized, although there was definite benefit, this was a very toxic dose that resulted in a high incidence of very symptomatic hand-foot syndrome and stomatitis. Investigators, very appropriately, around the country, around the world, began to explore a lower dose of the drug. And in fact, relatively soon, a dose of 40 milligrams per meter squared became very much accepted in the community. Clinical trials demonstrated the utility of this dose, essentially equivalent to 50 milligrams per meter squared every 4 weeks, but with considerably less toxicity. And in fact, very importantly, there was population-based data. When I say population-based, I mean oncologists essentially all were now using 40 milligrams per meter squared delivered every 4 weeks when using the drug in the treatment of platinum-resistant ovarian cancer. However, the dose that was in the product label by the FDA was never changed, never required by the pharmaceutical company to do that, because the community of doctors would do what's appropriate for clinical practice. But again, the branded dose is given at 50 milligrams per meter squared based upon the data in the label. Therefore, when clinical trials were conducted over a number of years, looking at other novel agents in this setting, the control arm, approved drug, pegylated liposomal doxorubicin, was given by the requirements of the regulatory agency at 50 milligrams per meter squared every 4 weeks. But again, outside of the clinical trial, doctors are not using this dose. Question, therefore, is what was the ethical justification for a clinician, any clinician, to place a patient on a trial where they could receive a dose of 50 milligrams per meter squared of pegylated liposomal doxorubicin, which would not be used because of the toxicity of that dose if the patient was not on the trial? What was the ethical justification? Again, the role of the clinician to do what is best for the patient The investigator in this trial was required to use 50 milligrams per meter squared. That is the question. Was this study ethical? Was it ethical for clinical investigator to give the dose, even though it was required in the trial, if they wouldn't use it off the study? And finally, if a patient was recommended for participation in this trial, did the clinician/investigator inform the patient that they were going to be receiving a dose of the drug that they would not get if they were off the trial? That their role of investigator required a higher dose, a more toxic dose, than if they were not investigative subject on this trial, treated by this clinician. And if the patient was not informed, what was the possible justification for this failure to inform? This is a very complicated topic. Of course, I use this example to emphasize this is a very real world issue, not simply an academic discussion. More to come, and I thank you for your attention.